You are listening to the Clinical Matters podcast with Lucas Furhauser and me, Nicole Vinitsky. Welcome to our brand new show.
Yes, welcome to a brand new show, Clinical Matters. It's brought to you by the European Association for Osseointegration, the EAO, a community of leading scientific minds in implant dentistry.
Lucas, we have chosen to call this podcast Clinical Matters. Could you please explain to our colleagues and listeners why we would choose that name?
Well, first, due to our backgrounds, I'm a true clinician, working every day in my clinics, treating patients, dealing with complications, complex cases. So I know how much knowledge there is out there and how hard it is to keep up to date with research and development occurring so fast in dentistry and especially in implant dentistry. And you, Nicole, you have one foot in the clinical world and one foot in the research world.
Yes, as a matter of fact, I do. I work 3 days a week with patients clinically, and the other 2 days I spend at research, podcasting, lecturing, and all other kind of fun stuff. What we want to achieve with this podcast is to condense clinical expertise and scientific knowledge so that the listener to the podcast can take straight back into the daily practice new, fresh knowledge to be used. But we don't intend to do this on our own. We intend to, in each episode, invite outstanding guests who will share their latest research and ideas, and always with a focus on how to apply this directly into clinical practice.
So whether you are driving to the clinic by your car, biking home from work, picking up your kids from school, or even relaxing on holidays at the beach, so this is a great chance to keep up learning. Each episode will focus on clinical relevant knowledge that you can actually take to your private practice and make us better in everyday practice. That's why we're here.
So, we want to say that this podcast is for everyone who wants to improve as a dentist to help our patients even better.
Yeah, exactly. Let's go.
So, let's do it.
So, today we are talking about bone augmentation. And we couldn't have a better guest in this episode. We'll be talking to the famous surgeon and educator, István Urban. It's a great pleasure. István, you received your medical and dental degree at the Semmelweis University in Budapest, Hungary. And then you moved to the US, to the UCLA and the Loma Linda University. And you're really a pioneer and one of the leading voices regarding bone augmentation. And it's wonderful to have you on this show. Thank you.
Great. Let's get into it.
First of all, thank you very much for having me in the show. I really appreciate the invitation.
You are more than welcome, and we are so honored to have you. Listening to you talking and looking at your lectures, I really want to describe you as an artist. Watching your surgery is like seeing an artist painting. It really is. And I would even go so far as to say that you would be the Picasso of hard and soft tissue management. It's really amazing to see your work.
Thank you so much.
So István, you are well known for your expertise in bone regeneration. Could you take us on a journey through the development of your augmentation techniques and what has changed in your approach over the years of your experience?
So that's a long story. After I finished dental school, I wasn't, 100% satisfied with everything. And then I started the program in oral surgery and medical school at the same time. And by the time I finished, I had a lot of surgical expertise, but I didn't do any grafting. I didn't even hear about really bone grafting, but I had a lot of surgical expertise. And then when I moved to the United States, I had two mentors first at UCLA. One was Dr. Henry Takei, the other one was Dr. Sasha Jovanovic. And Dr. Henry Takei is like the master of soft tissue, and Dr. Jovanovic was one of the masters of membranes. And then I moved to Loma Linda, and there I had a lot of support from the university by the program director, Jaime Lozada, and the whole program. And that's where it all started.
Great.
And that would be a very long answer, but I think we can come back to this, and I can tell you like little stories about, my first bone graft, for example.
Right.
Yes, please.
And maybe you can take us a little bit on the journey how your techniques are developed in the past and over the years. So you're famous for molar area, especially molar area in the mandible. This is really famous. So maybe you can describe it a little bit for us, for the listeners.
So when I went to Loma Linda, I felt like I've seen a couple of membrane cases. And I've seen that the flap has to be advanced. And I was like, okay, I know how to advance the flap. But I really learned over there, like I saw how to fixate the membrane. And then I thought, I can do vertical augmentation. And in the first week, I had lunch with the program director, Jaime Lozada. And I told him, look, I want to do vertical ridge augmentation. And seriously, the spoon stops in his hand, the freezing, 99, this is 1999, and he's looking at me, on a human? And I said, yes. I was like, but he just continued eating, and it was not much talking anymore. And I was asking. And 2 months later, he said, okay, I'll give you a patient.
So no one did vertical bone augmentation at this time? Or?
I mean, not me.
No?
But Dr. Simeon in Italy and Dr. Giovanni, they started to do it already with membranes. I've seen, a few, but me, no, I never done it. And, I was a resident. And, but I've never seen a mandibular bone graft in my life. No. And never did one. Never read an article how to do it. I was just like, and my first case that I got was an anterior mandible. And it was a 28-year-old patient. And, I was like, okay, well, the patient asked me, how many have you done? But nobody wants to read me, how many have you done? And I said, look, I haven't done any, but I know how to do it. And I really felt that I know how to do it. And the surgery was 4.5 hours. I was in a worse shape than the patient at the end. Almost needed an IV. I still remember getting out of the operating room. But the patient healed perfectly. And it looks like all the education I had, I was able to put it together in my head somehow. But going back to your question about, how it improved, because seriously, I mean, I got really lucky. I'm so thankful that they gave me this patient. I'm so thankful for everything that patient worked out, because then the university supported me with more patients. I started to do it. But honestly, looking back, I had no idea what I was doing. I just advanced the flap. I got lucky. But now, then it really changed. Because then, I was like I went on the lingual, in the mandible. And then I started to teach. And I was like, okay, how do I teach something that I don't even know how I do it? I just do it like intuitively. And so I went back and started to investigate, the anatomy. And then I recognized, the anatomy, what I'm doing is like accidentally pretty good. But how can I improve it more? And then this is how it came up with that I put together my experience and the anatomical knowledge. And I said, okay, well, this is what I do. This is the first step. This is the second step. This is the third step. And this way is going to work. And now I can teach it to other people. And that was one of the big steps. And there was other big steps in my development.
And Istvan, for the listeners who haven't seen your wonderful presentations, could you maybe give us a short journey through your bone augmentation, so step for step in a short way? Yeah. Is this possible for you? Like a technical, yeah, so that everybody can understand this on an audio way.
Okay, so yeah, so I would start maybe I would go for the mandible, because that's what we talk
Perfect.
about.
Yeah.
The maxilla is very different.
Yeah.
In the mandible, posterior mandible, like that we know that there's one thing we're so lucky with, that we have like the artery, the sublingual artery, we have the lingual nerve, the Wharton duct, and the sublingual gland. These four, mostly. What we're very lucky with, that's all embedded in a very dense connective tissue, which I always say it was developed by nature, by God, put it in there to protect the patient from the dentist. And so that's what happened with me, because that's how I got lucky. Because of the dense connective tissue. If the dense connective tissue is not there, I'm not sitting here for sure. Okay, I would be sitting somewhere in a very different place, in a very long, a small box maybe. Anyway, so the dense connective tissue. So that's number one. You have to know the dense connective tissue. Number two, you want to know that you don't want to damage any of this, and you don't want to damage, the diaphragm, which is the muscle insertion. And so we came up that there are 3 zones in the mandible. Okay. And so we raise a flap, which is crestal incision, 2 vertical incisions, and we do a mini vertical incision on the lingual to elevate the lingual flap. And we elevate the lingual flap until we see the mylohyoid muscle insertion, which is in from the retromolar pad until the second premolar is very close to the crest. And that's what we call the second zone, the high mylohyoid attachment or insertion. Behind that, there is the retromolar pad. And we know that about 6 millimeters apical from the retromolar pad is where the lingual nerve is. So the retromolar pad is something that's holding the flap back. So if I just tunnel and lift, which is my next step, that I tunnel and lift, I'm away from the lingual nerve, but it's de-anchoring the flap. Then up to the second premolar, the muscle is very close to the crest. And in front of that, the muscle goes down. So up to the second premolar, where I see the muscle insertion, instead of removing the muscle from the mandible, which would be I don't want anybody to do it on me, I'm just gently reflecting the muscle from the flap from the muscle. That's what we call mylohyoid separation. We keep the mylohyoid intact, we just separate the flap from it. The more anterior is the only thing which is more complicated, where the muscle becomes far away, and there's a long periosteal layer, which is now making the flap very unrigid. And I just go parallel to the flap, and I just scratch through the periosteum, and the whole flap comes up. Done. On the buccal, what you have to know is that you advance the flap at the very end, not at the beginning, because you have the nerve. And you advance the flap, you cut the periosteum at the beginning that your assistants can accidentally damage with retractors. So I do it at the very end. So after I did the lingual flap, I scrape some bone, or I take a trephine, put a bone meal, mix it with the biomaterial, take a membrane, and I fixate the membrane in the lingual. For the membrane fixation of the lingual, I have a handpiece and a screw, and I have pen tacks. Once I did that, I apply the bone graft, fixate on the buccal. That's pretty easy. And then I advance the buccal flap. Now, advancing the buccal flap is...
Maybe, Istvan, a little bit, could we go a little bit back? Which membrane you're using, because it has to be stable. Yeah.
So it depends what I'm doing. Okay. One is that we call the sausage. There's a history for it. So I will...
Please give it to us.
Yeah. I will maybe, after this. So if it's a horizontal augmentation that I want to make it wider, I use a collagen membrane, and I really stretch it out.
Yeah.
If it's a vertical ridge augmentation, I'm using still a PTFE membrane. Today we perforate it with a titanium reinforcement. But you can use a titanium mesh. You can use, some people like to use like a block or something, I think the flap should be the same. Okay, so membrane, if it's a vertical, a titanium reinforced membrane. That's what I use. And I like that I can only just scrape some bone, and so it's not so traumatic to the patient. Then at the very end, when I'm advancing the flap around the nerve, there are 2 things that I'm looking at. The length of the flap. In a big defect, the length of the flap can be very short, which is not the first thing you want to do in your life. So you want to select a patient which doesn't have a huge defect, so it's a longer flap. Because it's a longer flap, you can go with your incision away from the nerve, scallop it away. And then I look at the quality of the tissue. The quality of the tissue can be normal, native tissue. Select a patient like that who never had surgery, because then your job is easy. So a long flap, native tissue is your first patient. When you're going to scallop the incision, and you scallop through the periosteum only, which is less than 0.4 millimeters, and you go, if it's 0.375, you go 0.376. Okay, so you don't cut deep because the nerve is right there. Then we do something which we call the debundle. Around the nerve, there are like these little cross fibers. We do research on it. Some of them are micronerves to the periosteum, by the way. And we just play the guitar, tonk, 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 and that is eliminated. And then I put a blunt instrument and stretch. And I don't want to use anymore a blade for the advancement here. It's just, the blade is just opening the door and a very superficial stretch. And the whole flap comes up. And that makes the mandible at the end one of the easiest.
Right.
because now you have 2 flaps to close.
Yeah.
But what you're saying now, you make it sound quite simple, but it requires so much knowledge from your side about the anatomy and also, the gentle touch, how to handle the tissues. Because if you just handle them a little bit too hard or cut a little bit too deep, you will not be able to reach the results that you're doing.
No. It's very, very important. That it's like super. I say that, for example, when I elevate the flap in the mandible, I don't even use a periosteal instrument. I make the incision. Then I go back with the curette, reinforce the incision, and very gently start to pull with the curette, and the flap comes out. Periosteum is perfectly intact. So you have a beautiful flap. You look at the beautiful flap, and then when you basically scratch through the tissue, you see this beautiful incision away from the nerve. You see the beautiful debundling. You stretch, and you're like, okay. And the nerve is perfectly protected, so you can sleep better.
And to cut the periosteum, you use the back of the knife, or
so when on the lingual side, mesially, yes. Here, I'm using a brand new 15 blade. Right. I put a bite block to the patient's mouth, so when I'm doing this, patient's not gonna accidentally close. That's a good recommendation.
Good recommendation, yeah.
And again, I have to come back to your artistry in this, because hearing you talk about this is like you're writing a musical part or something. It's really, really amazing. You can see how this is really in you.
Yeah, now I wish I could tell this to myself 25 years ago, because that was a little bit of a development here.
So we heard about the membranes and titanium mesh we could use in this situation. What do you think about bone substitutes? We heard you are grafting bone, so you are taking autogenous bone. In which, how you combine it, in which ratio do you use bone substitute, and which?
I started with autogenous bone. I was like the biggest believer in fully autogenous bone graft. Then early 2000s, about 2003, when we started to add a biomaterial, xenogenic bone graft, into the autogenous bone. And we started to do like a 1-to-1 mixture. We still do that. But 25 years passed almost.
Yeah.
And so I always believed that, especially in the last 10 years, that, autogenous bone should disappear. Because we're here and everything is digital, everything is like, why do we still have to take some bone? It's still not there, but I think industry and, research is getting very, very strong not to use. And if we use maybe different types of growth factors, cells, mesenchymal cell research is ongoing. I think it should come in. But still today, I would say, even saying the new gold standard is autogenous bone mixed with the biomaterial.
Yeah. And do you think this is more stable than autogenous bone alone, or how was it in all the years?
What we have seen, and we thought it's never going to happen, that if a patient was very, very thin phenotype, thin bone, and you did this beautiful bone, and it's like perfect, vital, you put your implants in, and all of a sudden, in some of them, you will see that the resorption, the genetics is very powerful. If it was narrow, it wants to be narrow. Mm-hmm. Okay? It's like, if somebody is big, it's very difficult to take to diet for some people, and some people is just thin, and they don't get, big. So it's a little bit like that. So there's a lot of genetics in there. Yeah. And I think the biomaterials, which we use, is not so, they're not really resorbing, and that I think helps a little bit to compensate for the genetics.
Mm-hmm. Mm-hmm. Very interesting.
But when you're saying that, I would also like us to move a little bit into patient selection. You said early that you want a specific kind of graft and it should be healthy, non-scarred tissue. But what else? What kind of patient is suitable for this? Would you treat smokers? Would you treat patients with perio problems? Or where is the limitations?
So today I would say I almost never refuse to treat the patient. Okay. Unless I would say that psychologically the patient is not ready for this. If the patient has periodontal disease, we treat periodontal disease. If the patient is a smoker, the first thing I'm going to tell the patient, I am not doing the surgery. I'm going to do the surgery after you did the last cigarette 3 months later. And I will tell them, look, if you smoke, let's say a pack of cigarettes, and lucky enough in, my it's very rare that patients coming anymore. I mean, before it was very frequent, not anymore. Then if you reduce it to 2, there is like some very old studies show that, the capillaries are not opening up. So I tell them 0. Okay, the last one is, and I think one of my biggest success is to quit patient smoking. So smoking to me is a big no-no.
Good, you're doing something for the world and
exactly.
for the
And I tell them, look,
population.
now I have to do a very good job because you live longer.
Exactly.
So,
Yeah, that's true.
could you walk us through the role of the soft tissue management? This is a big topic for bone augmentation. So could you walk us a little bit through, and what importance for you has the keratinized tissue after what's around your implants?
Very good question. So, when I was trained originally, I was like, we had literature reviews in the United States every day. And I really liked some of the classical papers. But many of the classical papers were from machined implants. And one was like 1994, from Gothenburg. And it was talking about the, no need of keratinized tissue. And for machined implants, keratinized tissue was like, at UCLA, it was like, it was super important for them. But we felt, that maybe not so important because of some of the Swedish studies. But I was trained like that is very important. And now, to me, it's very, very important, especially in the mandible, especially in the lingual, but also on the facial. But for me, what is not important, to have keratinized tissue to do a bone graft. If the patient doesn't have keratin, I'm never going to do a free gingival graft before a bone graft. But after, to do like keratinized tissue is almost every single time.
Yeah. And how you do it afterwards, this is very interesting, I think, for our audience.
Okay. Now you're going to be very surprised. Maybe a lot of people are not going to like me. When I went to UCLA in 1998, Dr. Takei told us that we are not really doing free gingival grafts anymore because it's outdated, he said. And instead of that, in the aesthetic zone, it's recommended to do a connective tissue, open, to make it nicer looking. And for the posterior, instead of one big free gingival graft, because of the palate of the patient, especially in Los Angeles, patients are very, very sensitive for that. We started to take little, and that was Han and Takai published, little strip gingival grafts. So instead of one big, like 2, 3 small ones, which is very technically, it's tiring.
Yes.
But that was originally.
And very hard, technically. Like to shape them and to move them and to attach them. And
Yeah. And one strip, now take another strip.
Yeah.
And so, but that helped me a lot because when one of the collagen matrix came out to substitute, we started to use it. Okay, now I put it in and I don't have to do anything. And it was beautiful. And in 3 months, there's nothing. Why? Because then we understood that this is a perfect material to collect cells. And what was it collecting? Mucosa. And so then we were thinking a lot about it, and they were like, also the companies asking me, okay, what can we do with this? I said, well, you know what? What if you put a strip around it? And if you put a strip around it, the tissue will migrate from the strip, and I do a lot of those.
So like to give it the information. Yeah.
Yeah, it's just basically an information. It puts the foot down, not the mucosa cannot come back, plus it gives the biotic information.
so it's like attracting the tissue around
it's just graft, it's just migrating into it.
So now we're talking about all these small details that we love to talk about, because that's what's really important in dentistry. But I also want us to look at the bigger picture. Like, what does it mean for the patient? How many surgeries are they going through? How long is the healing procedure? What does the journey look like?
Very good question. So number 1, prevention is the best. Okay? That means like ridge preservation for thin phenotype patients. Okay? You extract in teeth and then it's like the whole thing will disappear. So ridge preservation for those patients, I think it's important, because once you have a patient who has a big, atrophy, it's going to take time. It is like a pregnancy. Okay? And even, in countries where they do everything fast, is 9 months for a human. Okay? So bone regeneration, you cannot make it faster. You can place an implant faster, but it doesn't mean that bone is mature. Okay?
Yeah.
Okay. You put a piece
biology.
you put a piece of block in there and 1 month you place an implant. What? Well, I mean, the implant is there, so you did place. But did you have bone? That's another question. But in general, so depends on the defect. But let's call it like a vertical defect. Classically was 9 months, like a pregnancy time. And it was like before. I always told them, the patient, like this is like a pregnancy. The patient understood, like it was no more explanation needed. This is now faster because we have different membranes, because we have maybe we reduced it 2 months, okay, or 3 months. Let's say 6 months, but we cannot really reduce it less. Because it doesn't make sense. And plus, it doesn't take that much of a sense when you want to this. I mean, now we're looking at patients for 20 years.
Yes.
I mean, who cares about 2 months?
I totally agree.
And you mentioned before growth factors, because this is also very interesting. What are you using for growth factors, and where are you putting it in to enhance your healing and maybe to make healing faster?
So, growth factors also, like when I still was in the United States, was already like really researched a lot. I mean, the first one we used was amelogenin, okay, for perinatal regeneration. And mostly for papilla was one of my, love affair. I mean, it's like I really loved the papilla, and we wanted to graft papilla with connective tissue and the amdogain. But amdogain is available for everybody. Then, the BMPs were studied. When I went to Loma Linda, Dr. Philip Boyne was one of the first one who did the big randomized clinical trial. That's how they got the FDA approval for dental. So BMP2 was something that I was very, very interested. Unfortunately, BMP2, however, is available in Europe for neurosurgery, the same product, and for orthopedics. And I knocked it off, but I'm very thankful because now we just submitted a big, we submitted for ethical approval, a big randomized clinical trial in Budapest for microdose of BMP2 in vertical augmentation. And don't tell it to anybody. I hope.
You won't tell anyone.
I mean, I think, the Summerville School of Dentistry is really behind it. I do it with Peter Windisch, who is a good friend of mine. And, but we did research, and I did research on this. We published on large animals that looks like you need a microdose, and the position of the growth factor is going to be key. Because what happened when it was approved, that, it was like, okay, it was expensive, but they bought it and they put it everywhere. Patient looked like this because it was so much swelling, and it was very expensive. And the result was like, well, in the middle, there's a big hole. And we figured out what the big hole was, because all these growth factors are communicating with not only the periosteum, but anything soft, where there's mesenchymal cells. Looks like in the blood clots is not so much. So you put it in the middle of a bone graft, you're hiding it from the source. And so you don't need such a big dose, which would not be so expensive. And you put it outside, we call it a lasagna. You put it outside, a microdose, and you see a much, much better result. Corticalization immediately on the top.
So it's important that the membrane is perforated, because
it has to be perforated.
Yeah,
exactly.
Yeah.
And the perforated we use this perforation because we did like 4 animal studies, and that was one. We wanted to have a membrane that is for the future, that is like communicative, and we tested the non-perforated, and then we came up with this.
I think it's really interesting what you're saying, and I think it connects with so many other things that we do, because it's not only what product and what material we use, it's also how we use it, which is really, really, really important for us to think about.
I think how we use it, what morbidity it can cause, what is the cost, and how it can be approved, and all the risks. And I think, I think research and also industry support and policy. Mm-hmm. I mean, this triangle will work in a smarter way together. I think that will eliminate autogenous bone.
Mm-hmm. Yeah, interesting. So we always want our procedures to be as safe and predictable as possible. And when listening to you say how important it is that we don't have any bacteria present. So I'm thinking that both means having infections around in the sites, in the bone or wherever, but also the hygiene the surgical hygiene. So do you think these are procedures that could be done in a private practice, or do you need to be in a hospital environment?
You can do this in a private practice. So in the oral cavity, there's bacteria. That's fine. But you should not have patients with dirty mouth, untreated periodontal disease. Like, I'm not going to do a bone graft in here if I have a 7 millimeter bleeding pocket in the upper left, because bacteria, by the time you suture, you're infected the bone graft. Mm-hmm. And so what I meant is and so you need to have a very clean mouth when you do the surgery, and you need to have a closed flap, not to communicate with bacteria, because that's food for bacteria. Also, it's very important how the neighboring teeth are. Like restorations. If you have a poor restoration neighboring tooth, don't get surprised if you get an infection.
Mm-hmm. And which antibiotic regime you have for your patients, because this is also important for our healing phase. Do you use it before or single shot? I don't think so, but or
That's
a long.
a very good question.
Yeah.
And maybe what I do is not even, it could be even improved in a way. Let me explain. So we do the same thing for the last 25 years, which is, if the patient is not allergic to penicillin, we give 2 grams of amoxicillin, not augmentin, not with clavulanic acid, just simple amoxicillin. There is no infection. We're not treating anything, we're preventing. Then we close and we give for another week 500 milligrams 3 times a day. But there is some articles showing that even a single shot for a bone graft could be sufficient. And I think it's probably correct. Probably the 2 grams should, because the way you close it, I don't see any bacteria going in there.
Yeah.
So we will go into a short break, and we will be right back after that. Enhance your career with world-class education from EAO. Sign up now for EAO's first and second certificates in implant dentistry. The first certificate is EAO's fundamental course, and brand new for 2026 is EAO's second certificate, which is the advanced level. With these courses running online only, you can study when you want, at your own pace, and at the time that suits you. Find out more at eao.org.
Welcome back to Clinical Matters with our topic bone augmentation and our famous guest, Dr. István Urban.
So let's dig into the sausage technique. That is something, I'm a prosthodontist myself, so I don't do any surgery, but I've always heard so much about the sausage technique. And yeah, you know, you
Maybe
have a story about
name.
it. Yes, exactly, the name, and I also saw you do it, but please give us all you have.
Yeah, so it's not a medical terminology for sure. What happened was that, we were doing bone grafts, and we believed, I'm talking about early 2000s, that you have to use a non-resorbable membrane for everything, for almost everything, except it's a tiny little defect. Then we use a collagen membrane, but for ridge augmentation. And I had a patient who in 2003 was my very first patient who had a complication, which was 3 fistula tracts. Flap was closed, everything was closed, no pain, no nothing, but 3 fistula tracts after 3 weeks. And, I couldn't sleep. Then I went back, I called the patient. Patient said, look, I have no problems, don't do anything. I said, no, we have to remove the membrane because that's going to be a big problem. So I went back, I removed the membrane. And then on the surface, the surface of the bone graft was dead. I washed it out, but I thought the whole thing is going to come out because I removed the membrane. But the rest of the bone graft was surprisingly stable, sitting in a blood clot, and I like to say the membrane, the bone graft started to talk to me. And the bone graft said, don't spray me the cold water. Just give me a blanket. And the blanket we gave was a collagen membrane. Not fixated, because it was already stable. But I thought the whole bone is going to disappear because there's no resolved membrane, so this has to be protected, the barrier effect and all that. And I told the patient, there was no CBCT. I told the patient, look, probably we're going to have to redo this, but let's wait, let's see. Look at the X-ray. X-ray looked pretty good. And when I went back, the bone was completely survived, and it was rock solid after 6 months. And that made me think. That the good thing that I recommend to everybody, that I took pictures of the complication, took pictures that I opened it up. So then when I looked at the pictures and said, I mean, you know what? I have the whole bone. So it looks like I don't need a non-resorbable membrane for everything. And that was the initial thought behind the sausage. And
so what is the sausage technique?
And so basically then I said, okay, well, I'm going to use a resorbable membrane to do a ridge augmentation, at least horizontally. I told to my friends, it's like, well, that's the worst idea on the planet. This is never going to work. I'm just like, you need to use this membrane for that. I said, okay, well, I don't think so.
Because they thought they were not stable enough, or
not stable enough, it will collapse, and the resorption time.
Yeah.
It has to be pregnancy time, it's like for everything. And so that was 2002.
Yeah.
And then I started to use first a synthetic resorbable, like longer term, and then I switched in 2006 already for collagen. And I really recognized, okay, so if I want to make this work, I have to stabilize the bone graft on the crest. How do I stabilize? I think, this is stretchable. When it's wet, it's stretchable. So I started to put pins like for the non-resorbable membrane. I knew that. And I started to stretch the membrane, push the bone graft up, stretch, put in a lot of pins, and went back. And there was like better bone quality because of the communication through the collagen and perfect bone. And I said, okay, now I can touch where the membrane can touch the tooth. Everybody at that time was like afraid of, because it was Gore-Tex membrane, it's difficult to use. And so let's make it more simple. Let's make it easier for everybody, less stressful, and for other people to use it. Mm-hmm. And then, in about 2000, I take pictures of one of them, like 2010 around. I said, well, it looked like a sausage. So then I started to call it sausage.
So you say that this is, you make it sound like it's kind of simple. Can everyone do this? Or how?
I think so. I think it's a little bit artistic because you're like forming, you're shaping the titanium reinforced membrane, titanium mesh. You like put it in, it's like done. But this one is like you're shaping, you're pushing, you're removing a pin, adding a little bit more here. Yeah, it's like. But I think everybody can do it, and I think a lot of people are doing it. Very popular.
So this is maybe very interesting. So would you recommend for a younger dentist or not a beginner, of course not, but if you starting with bigger bone augmentations, that you use prefabricated individual meshes because they help you, because you don't have to build the bone or to model the bone. So what would you recommend?
Yes, I would recommend it and not. Depends on, because I think they're overusing it. Mm-hmm. Number one. Number two, the material is important. I don't want to use something which is going to be difficult to remove. Mm-hmm. I don't want to use something that with the soft tissue is moving on. And if it's a thin phenotype, then 2 months later, you're really surprised. You did a good job, but there's a big hole because now you just rubbed through the tissue and now start to take that out. Okay, where do you make the incision? Because the hole is like 10 millimeters from the crest. Are you going to make the incision on the lingual now to take it out? Or you making the crest and then the whole thing is just a big hole? So I think for that, for a beginner, okay, we're also looking into this and working on this and modifying. We're using like a printable materials that are resorbing. Okay, but how long is it going to resorb? And still the problem with those, because now we started to use them, is what I just explained. That in a thin tissue is moving around, and maybe in 2 months you see, 10 millimeters from the head of the bone graft, a little exposure through, and then you have to take it out. Yeah. So
and then can you do something with it, or do you have to start over?
No. I mean, if it's 2-3 months later, then you will get bone, but not perfect bone anymore. And plus, it's a trauma. It's like, okay, that's a complication. You have to go back in there. I don't want to do that. So
therefore, you don't want to choose the thin biotype patients.
I do any biotype, but with the collagen membrane or the PTFE membrane, it doesn't matter to me. Okay. But I think, the development of this, and that should be the future, because it's going to be easier. Because what we're printing now, I put a couple of screws on the buckle, and I put on the lingual because I want to, okay? But maybe it's not going to be so much necessary. And it's going to be individualized. So I think the future with this should be printable, resolvable, customized, but I would say, okay, this is the phenotype, this is the defect. I want a softer one, thinner one. Print that. Then I just tell the computer, boom. Okay? Now, it's a huge vertical defect. this is the phenotype. I need more stability. I need a bit thicker one.
Yeah. So we all working with clinical matters. We all know the complications are part of our reality. When you experience the wound dehiscences, how do you manage those?
Okay, so wound dehiscences, I mean, I had not experienced a lot. I had one big one in the anterior maxilla, not in the incision line. One large one in the mandible, like 2 years ago. I thought I would never have one. I don't know why I had it, but so I'm not the best person to ask because that is not a problem in our practice, honestly. But when it happened, one of them, I just, it was an early, uncomplicated exposure. That means when you pushed around, there was no pus. Mm-hmm. And that you treat in a way that you look at the defect and then, okay, this is a horizontal defect. Okay, I would like to maintain this membrane there for the next 6 weeks, at least. Then I can take it out. What we have the experience, the soft tissue grows underneath. And now you will get 70% bone. Okay, not 100% bone. The other thing that I've seen on my patient was on the lingual, that is like a necrosis of the flap or something. So I get an exposure and an infection. When you have an exposure and infection, it's worse because you have a soft tissue defect plus an infection. Then you have to get back in there immediately. If you see pus, and then you will, it's going to be very difficult to save the bone graft. However, if you have an infection only without an exposure, then you could potentially do something that we call the CPR of the bone graft.
What is that?
Cardiopulmonary resuscitation of the bone graft. That bone graft. No, seriously.
But how do you do it? What's the practical?
But C is you go back in there. If you see, there's two types of infection. One is a low grade. The low grade infection is a fistula. In the fistula, I see in the first 2 weeks, very rare, but I would see fistula occurs between 10 to 21 days. Unless rarely you would see it later because maybe the noticeable membrane doesn't allow. Mm-hmm. Okay, but anyway, then if you see it, let's say 2 weeks, you see a fistula. I would take even a CT scan to see what's in there. And I would see a localized disintegration of the bone graft. Then it's a vertical defect. I don't really want to remove the membrane if possible. Then I would, maintain that with I would give it a course of antibiotics, maintain it, and go back in there 5-6 weeks. If I see it later, I just open, and you will get 80% bone. Your enemy is your high-grade infection. And that's when you do CPR. So what is the CPR? When you see a high-grade infection, you have to immediately open. Okay, and now you will see a dead bone graft. C is cleanse. Okay, you irrigate, you wash out.
What do you use for irrigation here?
I would just use saline.
Yeah.
And maybe that's enough. And we have it completely empirical and not scientifically proven, but we use a wide spectrum anti-inflammatory antibiotics. Like we just open a capsule, which is usually doxycycline. We mix it and we put it on the surface.
Locally.
Okay, locally.
Okay.
Okay, why? Because we say, okay, we cleaned out 90%, but maybe there is some. And with the left of the bone graft, that's still C, cleans. Okay? Then we irrigate it, really looks dead. Then we go for P. Why do we do this? Because anybody who wants to survive needs oxygen. So we want to give oxygen, perfuse with blood, which has oxygen. So we put that sterile blood, like sterile, like from the neighborhood, we put some, that's so it should be bleeding on it. Mm-hmm. So that's P, and then retain. We don't take it out, which is R, CPR. And we have pretty good results with that.
Very
but
interesting.
we don't see a lot. I mean, it's about 3%.
Do you use, or should your patient use any chlorhexidine to rinse or something? We know all the complications with chlorhexidine and bone. What do you think about that?
I think it doesn't really matter.
Yeah.
It's my honest opinion. But mine, patients, for the first 24 hours, they don't use anything, then they use it. Mm-hmm. So I don't see any negative effect. But I would be, if I would probably have a randomized clinical trial, I don't think that would be a difference, honestly. Because if it's closed, it's closed.
Yeah.
I actually want to go back to what we talked about before with complications, because you said that you only had very few complications. So you are apparently doing the right thing to avoid complications. What is that you're doing?
It's the patient preparation for complication, patient selection. Okay, heavy smoker, diabetic, uncontrolled, untreated periodontal disease, you will have a complication 90% of the cases, probably. Okay, so patient selection. Patient preparation for surgery, I think is one of the most, it's as important as the surgery. And that's what they're not looking into, okay, how clean it is. We even clean the tongue of the patient before the bone grafts.
Yeah.
Okay, we just cut the grass. And you're surprised how much it's come out. I mean, they're licking on the bone grafts. Okay, so patient preparation, then the surgery itself. You know, the flap, how your flap designed, how careful you do it, and how you close it. And then, of course, the postoperative management. Are you going to put a removable denture on a bone graft or not? Yeah, probably not.
We actually wanted to ask that also about the provisionals.
Yes.
What do you do with that?
Okay, provisional, and I think digital improved it so much. Let me give you one example. Let's say I'm doing a bone graft in here, and there is like a bridge, okay, a good provisional bridge. Okay, what are you going to do? Remove it to be able to do bone graft. And then are you going to do the bone graft and there's naked teeth? Okay, how do you clean them? You blow some, clean them off, like cleaning it. And then by you close the flap, like half of the tooth disappeared. Okay, how are you going to put the provisional back? So I don't want to do that. So I will remove, we're going to remove, and many times now you can print, obviously, the provisional. And I would like them to print 2 temporary crowns, which is perfect. And we cement them with permanent cement because I don't want them to pop off during the surgery. Okay, and the margin is closed, so that helps a lot. Plus, when I close, it's going to be very easy to put later. Okay, but for the first 3 weeks, we're not going to put that bridge back. We're going to make an Essex.
Yeah.
Okay, and I tell most of the patients that I don't want to put them in immediately. If you really demand it, 4 days you can have it. I can count on my...
After 4 days.
After 4 days. Yeah. But I can count on my 2 fingers how many patients want it in 4 days.
Because they understand when they've been going through such a procedure, they also want to do it.
Don't want to redo it. Yeah.
But I think it's a very big mistake to put it in immediately because that will be more swelling and maybe it's going to hit the... So anyway, maybe you put it in 1 week. Okay, you cut it back, it doesn't matter because it's like an Essex. But then the tissue will settle for the next 3 weeks. And only after I will put the bridge back. Then I'm going to, very carefully, we cut off if it's not coming out, we cut off those and put the bridge back. Perfect. If there's no abutments, again, Essex and a Maryland bridge, up to 4 teeth. If it's more than 4 teeth, like gigantic defects, those patients are accident patients or something like, then you give them an Essex, a rigid Essex. And, in my experience, they're perfectly fine with it, number 1. Number 2, because of the bone graft, the face will improve so much that all they're telling me, please, doctor, wait longer, make sure it stays like this, make sure it's not,
Yeah.
Because they like what they
see the difference already.
Yeah. Very interesting. You have overseen countless of years of bone augmentation cases. How you see the long-term outcomes? And do you think short implants could be an alternative? Do you use short implants?
So when I'm doing surgery, in my mind, 1,000 surgery goes on. When I do something and I make a decision, it comes off. This is what I did, this is what I did, this is what happens, okay? Then I know exactly today what makes it. I don't want to say everlasting, but that's what I want to do. I want to achieve everlasting. And what mistakes that I've done that gave me like a complication. For example, periodontitis we don't see a lot in regenerative bone, but every time I see one, like my heart is like, and I see like what I could have done differently. And I see what I could have done differently. Okay, we can talk about that. But I see then, so we record all my first 36 patients, that's from Loma Linda. And then from Budapest, there was 36 patients we published 2009 or so, 6 years. Now we record anybody who's still alive and I can get it. And we got a good number. And still, up to 20 years, there was not much of a difference between the implants. But however, our patients are coming 3 to 4 times to the hygienist. We take every year, like we took an X-ray every year, and then every second year after, a decade. So I see a very good outcome with this. But of course, I do think that short implants have a role. So when would I use short implants? Especially posterior mandible, but I would look at a couple of things. Recently, there was a publication. Then when they looked at this, and I completely agree with this, and I already knew this by myself, that there is a big difference in success if in terms of let's say you have the most posterior tooth, you have the bone, and if it's more than 4 or 5 millimeters jump down, and there's an implant, there's going to be a problem. That is a big precursor for periimplantitis. So let's say if I would have that, let's say this is my bone, I would. So
you're talking about, just to be clear, the bone level of the adjacent teeth in a big comparison to where the bone level is where you're going to place the implant.
So I would rather skip that spot and put it behind, let's say, 2 implants and a mesial cantilever to get a more natural and gradual. Okay. And that's what, in general, short implants maybe, in posterior mandible, yes, but not I would, in a young person, I would put in 4 millimeter implants with big, misalignments, maybe not. Mm-hmm. Short implants, okay, where? Short implants where? Here, there's a, can I put an implant down here and up here? So
you're showing the lower mandible anterior and posterior.
And maxilla, upper maxilla, anterior. You cannot do that. No. So it's more posterior indications.
Yes. So posterior areas, both mandibular and maxillary. Could be an option for short
but
implants.
many times your bone is narrow. It's all the way down here, and that's young. Okay,
and
that's
a short implant is usually wider, so you need the
augmentation again. Yeah.
Great. I think we have learned so much, and it's been so inspiring to listen to you. I just love how you want to do things in the best way possible. One last question that we would like to ask. If you look into the future, how do you see bone augmentation in, say, 10 years?
I think, an idealistic goal for me would be to have materials which can be, biologics, cells, whatever, that I don't have to harvest anything from the patient. And personalized, as I described, maybe personalized between phenotype, capacity of the host, the defect, and I personalize, can push a button, okay, this is what I want. Mm-hmm. And then
you
I can
the graft in the shape and
I can manage then the closure. And theoretically, which is not going to happen, not even to be able to close, I don't have to close the flap. And then I can leave it open because it will resist any infection.
But do you think the cells in it is important? So we have to find the cells before to put it in this substitute
cells
harvested from growth factors.
Controlled growth factors. Okay, this growth factor is going to call this guy and this cell to come in and do this.
Yeah.
So we've now listened to you, and you have so many interesting things to share. If you should pick 3 takeaways for the listeners, what would that be?
I think one of them would be to have a little bit of listen to my history, that you can see that anybody can become what they dream of. I think the dream is much more important than anything else, and that your willingness to go through your dream. And my dream was to make a very good bone graft. And the second one is that I think you should also be always, look at the best interest of the patient and try to progress. And how the third one would be is how important the whole process is, from patient preparation until, the whole process that you go through every time. All those
that you don't skip a step.
No, you can't skip a step.
Fantastic. Thank you so much.
Very interesting. Thank you so much. It was a great session. It was really fascinating.
But thank you very much for having me.
Thank you so much for coming.
Thank you.
That was a really fascinating conversation.
Yeah, it was really great.
So for all you that have listened to this podcast, thank you for joining us on Clinical Matters. It's been a real pleasure having you with us.
Join us next time for more great insights and tips, all to help you deliver excellent care to your patients.
And keep doing the work you do. And in the meantime, please follow, rate, and review the podcast. It really helps others to find it. See you next time.
Bye for now.